I'm happy to announce that we are going to start this webinar about how to manage the challenging cases of refractive surgery from the cornea till the retina. We are going to start by prevention of the Lasik Ectasia by Renato Ambrosio, cross-linking challenging situations causing Mazzotto, surface ablations, Miguel Richichi from Italy, Lasik I'm going to cover, phakic IOLs, Dr. Eric Martins from Belgium, smile complication, Susan Jacob from India, CTK, Tara Nagar from Cairo, Egypt, and the posterior segment challenging situations management by Dr. Ahmed Al-Isawi from Cairo, Egypt. I'm happy that Eva is covering and sponsoring this webinar for continuous medical education. So please, can I ask Renato to start the first talk about how to prevent post-Lasik ectasia.
Thank you very much, Ashraf. So it's a pleasure to participate in this webinar. This is one of my favorite topics on prevention ectasia. I have financial disclosures, including Oculus, but my main financial disclosure is with my patients to help them the best as possible doing refractive surgery in the safest way as possible. We have many colleagues that collaborate for the research that I'm presenting. When you think about progressive ectasia, it's very important that we see the literature. The first case presented was in 1998 by Seiler. The first 3 cases on high myopia treated with Lasik. Today, this is not done anymore. We do phakic IOLs for those cases, but the impact from the procedure lead to the corneal decompensation. But a few months later, he also presented the form-fruit keratoconus as a cause of iatrogenic progressive ectasia, and he defined form-fruit based on the front surface curvature. Looking at these 2 cases, we can allude to the biomechanical decompensation of the cornea pathophysiology, which is related to the corneal resistance itself, the biomechanical properties, and the impact from the environment. The impact from the environment correlates to the laser vision correction procedure and also to wire rubbing. Any cornea may develop ectasia. So understanding this concept is critical. And the first very important concept is telling patients not to rub the eye, because eye rubbing causes ectasia and aggravates keratoconus, which is not the same thing. And that's a main message that we have in our Violet June campaign. It's also important to understand that patient expectations should be carefully identified, and this is part of the screening. When I did this first review on Lasik complications back in 2001, it was very clear that early keratoconus detection was fundamental, but we should go beyond that. And also beyond the 250 residual stromal bed, which is important, but we would suggest half of the cornea to be preserved. It's important that we understand some very large series, like the Steve Schallhorn series, operated from 2007 to 2011, 3,000 Lasik procedures. And we have cases on the ectasia cases, the green bars, with a normal topography and even normal tomography. And also cases in the stable, the blue, no ectasia cases with very abnormal. 1% of the normal cases had irregular topographies, and he called form-fruit keratoconus as an interpretation of the corneal imaging tool. In my opinion, form-fruit keratoconus should be understood beyond that. It's not a consensus. There is no consensus on what is form-fruit keratoconus. My humble consideration and contribution is that form-fruit keratoconus is a patient with very high susceptibility for ectasia progression. And the literature comes with a fellow eye with very symmetric disease that could be a form-fruit keratoconus, but probably the best definition is by Jay Krashmer as a mild disease, subclinical disease. It's important that we see cases like this one. The patient is 32 years old, residual stromal band higher than 300, PTA lower than 0.36. PTA is defined as a parameter by Marconi Santiago as for normal topography cases, higher than 0.4 will be a high PTA. So in this case, it was 0.36. And this patient with a little bit of irregular corneal topography would come as an important point that subjective classification is an issue. So this was a patient that started this study that I sent these maps to 11 colleagues, and the classification varied from 0 to 3, but the mode was 0 of this case. If you change the scale, it's important that the 11 classifiers, 9 out of 11 would have a different classification than his own classification with the other scale. With a 0.5 normative scale, the mode is still 0, but varying from 0 to 4. So the subjective classification is published in the JRS 2013 is a very important weakness that we have when we screen cases. So we need to be objective. And how to be objective? We need to go to tomography and understanding the tomography in an objective way. And that was the effort that we've done with Michael Bellin to get numbers, and the deviation from the normality is here from with a cutoff from around 1.4. That will be a very good cutoff for identifying ectasia susceptibility along with ARC-max. And I will allude to the sensitivity and ROC curves in a study that we've done recently. It's important that we see cases like this one. We have our colleague Derek Alnagar as one of the presenters talking about smile complications. And this is a patient that he published the first publication on smile ectasia. And he sent me, he was so kind to send me the U12 files from the Pentacam so that I could do a very nice analysis. And this patient is a patient that has a very low curvature, but still keratoconus. This is important that we call this low case keratoconus. A couple weeks ago in CareNet, there was a consult of a patient with a 36 years old engineer with a 20/20 with a -2. And he sent these maps, which you cannot read at all. But I was able to ask for the U12 files and again do a very thorough analysis. This is the curvature map with the 1.5 absolute scale, the Steve Kleis scale. And you see some TKC abnormality, even though with a low keratometry, 44, 5.5, and 5.4. And this is changed if you go to the scale with a 0.5 and now with a 0.25 with a very sensitive scale. You see this skewness here, which correlates with high IHD. And this is important that we go with an objective evaluation with a tomography data that we see abnormality. But here in the quad map, it's not so obvious, but if you go for this, abnormalities here are identified. And this patient is, in my opinion, not a keratoconus, but a foam-fused keratoconus bilateral, and we come with some other examples of that. This is another parameter, is a PRFI, it's a Pentacam Random Forest Index, that you see it's higher than 1.4, 1.5, which is when I see some suspicions about topography and tomography. So the conundrum of ectasia is now 20 years. We have this very good study from Bohak with 30,000 Lasik procedures. She had 10 cases of ectasia, and 3 out of 10 only had a lower residual stromal bed than 300, and only 2 higher PTA than 40%. And all the cases were seen with a relatively normal topography. In our series, 3,278 stable cases with at least 2 years follow-up. Now it's 5 years follow-up, I must say, and 105 cases that we collected internationally with cases that we had tomography before. You see that the cutoff values are not so good with the classic parameters, including age. PTA and residual stromal bed do not explain. So we have to go and look at the cornea curvature and tomography and see that it's very important that people obey the similarity, the asymmetry. The IS value is a very low number of cases. Only 2% of the stable cases have higher than 1.45 here. The D is much better, but still lacks. You have about 59% sensitivity, and we have to go beyond, and it was part of the thesis from Bernardo Lopez that we improved the sensitivity. And looking at the brain formula, we have the integration with the relational tissue alter so that we improve our sensitivity. But you still have cases here that should be improved. So we have to go and improve looking at biomechanics. Biomechanics is very important that we see the first, actually, this is my quote as the ectasia susceptibility in 2010. This patient had Lasik in in the late 90s and had ectasia, did not do any surgery in the right eye. And looking at the right eye, which is 2015, this is corrected, you see abnormalities on the D and also in hysteresis. We improved our ability to look at biomechanics with the corneal deformation from the shine fluid dynamic imaging, which takes 141 frames in 31 milliseconds. And this is objectively analyzed by many parameters like the display from Paolo Vinciguerra and Ricardo Vinciguerra that got the award on the Trautmann Award in 2017. We combine the data with tomography and biomechanics, and we have the TBI, which is an epitomize of the ectasia susceptibility. And you see the cutoff values for detecting the clinical ectasia cases and the 94 very asymmetric ectasia cases with normal topography based on very objective criteria. And let's go back to that case reported, and you see she's 2015 -6. She would qualify for LASIK based on this criteria. Maybe you see some irregularities. Here's 3 different scales. The same scale, Ambrosio 2 scale, you see very similar mapping, a little bit of irregularity on the posterior float, but the PRFI has a borderline value, and this patient gets to be very much abnormal if you combine the data from tomography and biomechanics. Very interestingly, the son of the patient with 11 years old, 2020, this is corrected, is in both eyes with a high TBI 0.52, 0.63. And this is a patient you have a little possible here. And this patient is really the patient that should not rub the eye because he can progress. We are aware in the literature that we have cases reported with the lower sensitivity of the TBI, and it gives us the opportunity to improve artificial intelligence. That's great work done by my group in brain. The 25 international centers, I highly thank them for the collaboration to get a very impressive 543 normal topography cases, and we could optimize the function so that we improved the sensitivity from 75% to 85%. This is important that we see some cases down here. These are the cases that are probably the unilateral ectasia, not keratoconus. True unilateral keratoconus does not exist, and I love the wisdom of Yoda for that message, but it's very important that we acknowledge that unilateral ectasia is possible, and it can be unilateral due to the mechanical process. This is the case that highly exemplifies this. This patient has a ring in the right eye with an excellent result, probably the best results that you can get, and that's because the cornea is not abnormal in terms of the structure. It has a warp because of the eye rubbing that the patient admits to have, but the fellow eye is very, very, very much normal. The patient was sent to Denver Einstein for follow-up many years after the surgery, and everything is normal, including epithelial thickness, the Young-Gatinel score, and the tomography and biomechanics a few years later is still very normal. So it gives you the idea that unilateral ectasia can be observed and documented based on multimodal imaging. Multimodal imaging goes to microlayer tomography, which is epithelial thickness. Here you have a foam fused eye, the fellow eye of a patient with mild keratoconus, and you have moderate keratoconus and advanced keratoconus. And you see here the thickness and the epithelial thickness. You see the thinning on the epithelium on the apex of the cone, which correlates to the front elevation mapping. This is also the case that I sent to you. You see the epithelial thickness on the artemis with the high frequency ultrasound, and also on the OCT, you see the correlation of the effect of the ring for therapeutic procedures. And this, of course, was initiated and pioneered by Dan Reinstein with high frequency ultrasound, and now with the great work by David Huang and his lab, especially Yang Li, we are able to segment with the OCT imaging so that we all can do epithelial thickness, and I'm sure we'll talk a lot about that for therapeutic purposes. Conundrum has come to the point that we know that ectasia has been reduced. It's very important that we understand that we need to go beyond detecting ectasia to keratoconus, detecting keratoconus to define ectasia susceptibility, the biomechanical impact from the procedure.
Thank you, Ambrosio, for your talk. I think your study and the studies of other colleagues really changes the mind of a refractive surgeon, because just 10 years ago, each patient go to the surgery without any without any fear, and also a refractive surgeon do not take in account nothing about corneal biomechanics. So this is important to improve our safety and also to give always the best offer to our patient. So thank you very much.
Thank you, Renato, also, but I have one question. Is it nowadays, in any case of controversies, that when we examine the patient, we see everything is fine, do we need to impel epithelial mapping with the corvus, with the pentacam, the three, to take the most safe decision for refractive surgery for the patient?
Well, it's a very good question, Ashraf. And I am not the refractive police saying you should not do surgery if you don't have this map or this exam. We should understand that we have evolved, and every center, every refractive surgeon in the world should do whatever they think it's safe and worth to do. But I would say that a lot of people come, everything looks normal, but the pentacam has a D of yellow. It's not everything normal. If it's everything normal, everything is normal. But what is everything? So everything is normal, but I have just done a topography and a central corneal thickness. So you have done 2 exams, which are very important. And I remember when I did my training in the late 90s, we are debating if topography was essential for every refractive surgeon. I saw this debate, and I did a survey in a meeting in Brazil, and 25% of people did not do topography in every case. Even some of them had a topography at their clinics. So we are evolving. Eventually, in 5 years, 10 years, people would say, oh, we were doing Lasik without tomography. Maybe they will come to say that tomography was never needed. But I would say that having the data is important for understanding ectasia susceptibility. And we never know everything, but we know more than what we knew a few years back.
Renato, I have another question. What do you think about the evolving technology? I speak about evolving from shame flag tomography to OCT tomography. What are your advice, and what is your best opinion about this one and the other technology?
Well, I do believe that both would work together. Tomography with the blue shine fluid light, the visible light, has advantages over the OCT. The OCT definitely has many advantages over shine fluid. If you see, the technology of shine fluid has come to the limit. I think it's, you can improve a little bit the sensitivity of the camera, it's true, but it doesn't get much better than that. The OCT, no. The OCT, I see developments still to come. But if you consider 2 wavelengths will give you a lot of information about the corneal structure, about corneal optics. Maybe even index of refraction can be the bulk. So I would say that the best machine would integrate. It's multimodal, beyond but not over. Coming to the idea, I have a shine fluid, throw out your placido disc, not true. I just see the talk from Eric has beautiful slides on dry eye, and this is pretty much placido disc.
Yeah.
You need to go beyond but not over. But I believe the future relies more and more on OCT technology.
Okay, thank you.
Thank you, Renato, so much. Thank you so much. Now I'm going to present Cosimo. He's my friend, and we are sharing a lot of webinars together. When it comes to cross-linking, it's an easy procedure, but it has some challenging. Anything can happen during this procedure if you are not taking the measurement and the right way to do it. Please, Cosimo.
Okay, can you hear me?
Yes.
And you see my slides? Okay.
Yes, clear.
Perfect. Thank you, Ashraf, for the invitation. Thank you to Pharma also. So I speak about complication of cross-linking. You know that the first publication about the complication of cross-linking intended as a loss of 2 or more Snellen lines of corrected distance visual acuity was published by Theo Seiler in 2009, and the complication occurs in about 3%, with a 95% confidence interval between 0.6 and 8.5. What made the progression rate was 7.6, and the percentage of AIDS or corneal scarring was 2.8 with a stereo infiltrate. What Seiler found was that the complication rate could be less than 3% if the K max at the time of enrollment is inferior to 58 diopters, and also less than 1% if K max is inferior to 58 diopters and age of patient inferior to 35. This is the publication of the 10 years result. You can see the mean age without affecting visual acuity is about 38%, while the persistent age of scarring affecting visual acuity was about 3%, is comprised between 3 and 8%. Also, the endothelial cell loss per year was about 2%, so a little physiological loss of the retreatment rate were very low, between 3 and 5%, with over 95 stability. This was my article on pediatric population at 10 years follow-up, and you can see that we had a temporary AIDS in about 12%, and the overall progression rate was 24%, but we had only 6%, from 3 to 6% of corneal transplant and retreatments due to scarring or you know that geographical, ethnic, environmental conditions may negatively affect the safety response to cross-linking, also facilitating the incidence and the severity of the complications. I mean, if we treat an advanced keratoconus just at presentation, if we had vernal keratoconjunctivitis, blepharitis, allergies, if we live in a sunlight overexposure, we do severe eye wrappers, poor hygienic conditions, or environmental factors. If we had low compliance for medications, for medical control, for postoperative control, we may affect negatively the response to cross-linking, increase the incidence of the complication. This is my flowchart of complications. So for simplicity, I have divided the complication in temporary and persistent. What I mean temporary is something until 6 months after the operation. And I mean persistent over 6 months to over 1 year. And what we may have after cross-linking, especially in EPOF, we have corneal edema, we may have AIDS or scarring, we may have also, unfortunately, melting and perforation. So we can divide the complication in infectious, bacterial, viral, fungal, parasitic, trophozoite, but mainly cross-linking complications are related to contact lens, to poor hygiene, to blepharitis, and the most involved agents, infectious agents, were Staphylococcus, Streptococcus, Escherichia coli, herpes virus, fungi, and also acanthamoeba. You know that we may have also wound-related complications. With wound-related complication may be of epithelial origin, of stromal origin in particular, and also involving the endothelial layer. In particular, the involvement of the stromal could be either if we have corneal opacity in the preoperative, also box stria, marked evidence for stria, or something like corneal dystrophies that were not diagnosis, and or scarring process. And also with the endothelial one, it may occur with thin corneas for hypotonia of the stroma, or stromal dehydration. And if we have keratoconus associated dystrophies such as Fuchs endothelial dystrophies, polymorphic posterior dystrophies, and amorphous. You know also the importance of genetic factors of the environment and the ocular surface diseases. Take home message that cornea is always sterile at the end of every cross-linking procedure. This is really important. So it is not the cross-linking to give infectious complication. Cross-linking is the therapy against infectious keratitis. So the causes of cross-linking complication as linked mainly with contact lens bandage, with poor hygiene, with poor patient compliance, with the environment, with ocular surface disease not managed, not diagnosed, such as blepharitis, pre-existing dry eye or meibomian gland dysfunction, corneal scars, also treatment errors, patient selection, surgical technique application, such as bad focusing, wrong riboflavin administration, lack of consistency in the application of the technique. Yes, I agree with Ashraf that it is a simple technique, but you need consistency to achieve some results and to avoid complication. This is one of the cases of acanthamoeba keratitis published by Paolo Rama in Italy. And we may have epithelial defects such as erosions or ulcers after cross-linking, and you need to suspect always an infectious origin from contact lens, from hygiene, and from ocular surface problems. So also we may have nummular keratitis that are mostly from fungal origin, and Candida and Aspergillus, and also Bifusarium. A wide of sterile infiltrates. We may have fold of the descendant membrane, corneal edema, and AIDS. I show that also in Epion, we may have punctate epitheliopathy or striate epitheliopathy that generally regain normality after contact lens bandage and lubricants. This was the first international report. I published the first international report of AIDS after cross-linking in the journal, in the Clinical Experimental Ophthalmology. And it was concerned with the presence of corneal scarring and with the Vogt stria that were most evident in this patient. What I want to say is that we have a completely different clinical appearance. We need to distinguish the AIDS of cross-linking from the AIDS of refractive surgery, such as PRK. They are completely different clinical entities with complete different pathogenesis, with complete different clinical appearance and also therapeutic response. And also the influence on visual acuity is completely different. Also the therapeutic management. This is my classification of AIDS with the confocal microscopy that I have published in the ocular surface. And you can see if we may graduate the AIDS in 5 steps. G1, G2, G3, generally this kind of hyperdensity of the stroma generally does not negatively affect the visual acuity of the patient. On the contrary, it increased the refraction index of the cornea, so patients see better in these cases. While if we have a persistent corneal scarring, so this could affect negatively the visual acuity. So we have in G4, G5, and this could need to be managed. You know that we have less than 3% in Europe and the USA, but the percentage could increase if we are in geographic areas with sunshine and higher percentage of infectious keratitis that can be associated. Remember that when we have AIDS, we may have a great corneal flattening that is progressive. So we may have also over 12 diopters, like in this case of corneal progressive flattening. So AIDS may induce a corneal thinning, an Icl progressive flattening, and also hyperopic shift that are not desirable in a cross-linking patient. Take a look to these bilateral AIDS with extreme corneal thickness reduction. So this is a progressive flattening with hyperopic shift that was not desirable from the patient. And you look at, if we use continuous light, we may have more AIDS than if we use pulsed light treatment. So we have published with Miguel this opportunity to use the pulsed light versus continuous light, because we have a lot of advantage. We increase the demarcation light depth, we improve the stromal oxygenation, but in particular, we induce less microstructural damage, less AIDS with pulsed light. And this was confirmed by these authors in Japan that confirmed the less microstructural damage, less risk of permanent AIDS using the pulsed light. So we need to understand that the Dresden EPIOF protocol had the higher percentage of AIDS, and they accelerated the pulsed light. We reduced the percentage of AIDS under 1%, and the AIDS will be absent, I think, in the new and future EPION optimized protocols. In particular, I would also to say that we need to stress the concept that when we combine cross-linking with transepithelial PRK, and so we do combined treatments, we increase the percentage of the risk of AIDS development, in particular if we use the Dresden protocol. So we need to use customized accelerated pulsed light protocols, because we have the ablation of the Baumann lamina, so the percentage of AIDS in this case could be higher. The steroids are the most important drugs to manage AIDS, of course, and sometimes we don't be afraid to use for cataract or steroid response hypertension, because the consequences of suboptimal treatments or failure to prevent recurrency are generally generated by the fear to use steroids for a long time. So in this case, we need to use for a long time. Take a look, another problem. This is really important. This is a barn of the endothelium. We may have an endothelial hot spot. This is a barn posteriorly to the endothelium. Generally, the causes of the central endothelial barns or hot spots are given to the stromal expansion using a hypotonic solution to expand the stroma. It is not a good idea. Please use the nomogram to treat thin corneas. And also it could be related to stromal dehydration, to bad focusing, or to patient compliance during correct UV calibration. The last is the dry eye. Generally, cross-linking doesn't use dry eye. Generally, dry eye is pre-existing. So we need to diagnose dry eye before doing cross-linking, because generally the nerves modification, as I have published in the American Journal, are temporary. We may induce only a temporary dry eyes, but with a good recovery after 6 to 12 months. So if we had a persistent dry eye, we had a problem before. These are this is a flow chart of the management. Of course, you can manage with antibiotics, antivirals, antifunginin, antiparasitic, antitrophozoides. The wound-related could be managed with steroids, of course, with acetylcysteine, regenerating agents. The edema could be also managed beyond steroids with hyperosmolar osmotic agents, and all necessary to manage these different conditions. So to conclude, I want to say some take-home messages that cross-linking represent the fair choice therapy in the management of early progressive ectasia. Of course, the complications are rare, especially infectious keratitis, because cross-linking generally ends sterile. The major part of the wound-related complications complications such as edema, AIDS are temporary and well manageable with pharmacological therapy. Patients and family members should be aware that temporary glare disability is possible in a often combined treatment in particular, but we need to early recognize the cause of complication. It is mandatory to prevent persistent corneal damage, and we need to do appropriate and timely therapy. Is crucial. Pre and post-operative treatment of predisposing corneal and ocular surface diseases is essential, and also the pre-operative parametric analysis. Consistency in the surgical technique application, the focusing, the riboflavin administration, the equipment calibration, the pulse light, and also the control of environmental conditions such as sunlight exposure, contact lens, hygiene are fundamental, and the patient and family members compliant, it's also essential. Thank you very much.
Thank you, Cosmo, so much. It's a very highly informative presentation. I have one question, and Dr. Ahmed have another question. Some patients you do cross-linking and you find everything went fine and with the same instruction to the other patients. But you sometimes will find a haze superficial. When you are going to take the decision to do a PTK for this haze?
Oh, generally, you need to manage the superficial haze with calm. You need to wait. You need to wait because generally with the corneal collagen turnover, generally haze tends to disappear. You need more time in this kind of haze. Generally, you need to wait at least 6 months to 12 months before to do a PTK.
Okay.
And managing with steroids, acetylcysteine, and all the drugs possible to reduce the haze.
But you do PTK if the haze persists for 1 year?
Generally, only if these affect negatively the visual acuity. But it is not of current work. Generally, we never do PTK after cross-linking.
Okay. Dr. Ahmed?
Yes, thank you, Cosimo, for the nice presentation. I have only a question here about the combined cross-linking with the PRK. As you have mentioned, this is usually followed by a very strong haze in the post-operative period. I would like to ask you if you do any kind of modifications to your surgical technique, particularly in the PRK. Would you minimize the exposure to mitomycin C? Which concentration would you use? And as for the cross-linking, would you use the pulse light? Would you change any parameters in your fluence or anything in order to minimize the haze post-operatively? If you would remove the epithelium using alcohol or not, this may happen. I mean, it has a factor in the development of haze. So I'd like to know your opinion about this.
Okay, generally we do a trans and all surface laser ablation. So it is the laser that removes the epithelium. So we don't use alcohol. I think alcohol is stimulating on keratocytes and AIDS formation. Yes, we have completely changed the product. I think Miguel will speak about this in his topic because we don't need to use 30 minutes of corneal soaking, riboflavin. We avoid dextran solution. We use hydroxypropyl methylcellulose. We do only 10 minutes of corneal soaking. 10 minutes of corneal soaking without dextran. We don't use the Dresden protocol, never for these treatments. No 30 minutes of UV continuous light because we may have AIDS. It is sure. We use accelerated pulsed light nomogram with a duration of UV exposure of 10 minutes, 12 minutes, no more. It is sufficient to have a good result, to stabilize the cornea and to achieve a good. And also we use mitomycin 0.002% for 20-30 seconds, because it is really important to use in these combined treatments. And we use also steroids since the first post-operative day. we use steroids since the beginning, and we go with the longer postoperative time to prevent.
Sorry.
I can add a thing to what Cosimo said, because this is one of my topics, as you know. The problem of AIDS for combined treatment, as Cosimo said, is just for excessive cross-linking power. In my experience, and now I have more than 800 eyes treated with the combined, I just have one complication that was by infection, not AIDS. The problem of AIDS after combined treatment is not due to the keratocyte activation, because if you do cross-linking after excimer laser ablation, you kill the keratocytes. So you can have some AIDS, but in real is inflammation, not real AIDS, because there are no keratocytes. So if you use the right power for cross-linking and do trans-PTK or trans-PRK, personally, I have not experienced AIDS. And we have to use steroids, as Cosimo said, from the beginning, always.
Yes, Tarek.
I have a question regarding using steroids with cross-linking, because cross-linking haze is a totally different situation than PRK haze. The mechanism is totally different. And I always hear Dave Seiler saying that the steroids used with cross-linking alone is not preventing or treating haze. But maybe because you're using PRK or trans-PRK or PTK to start with, and even with using Mitomycin, you might need to use a steroid. But if you're using cross-linking alone, you might not need to use steroids for a long time or even to treat this type of haze. Are you agree with this or you don't?
No, I'm not completely. I'm not completely agree. I want to explain you, but the use of steroid in this case is to reduce collagen deposition. When we do a cross-linking, we kill the keratocytes. We wait for keratocyte repopulation. I have published a lot of confocal microscopy studies in this topic, and you know that the collagen that is resynthesized after have a high molecular weight compared with the collagen, with the previous collagen. So we need to control. We are doing some scarring control because we need to strong the tissue without losing the transparency. So the steroids are useful for 1 to 3 months, of course, not over generally, but in the first 3 months are very useful.
Cosimo, last question, then we go to Miguel. The question from the audience. Do you use mitomycin in cross-linking as a prophylactic measure?
No, only in combined procedures.
Only. And what is your protocol in infective keratitis?
Infectious keratitis?
Yes.
It depends on the cause. Generally, I try to understand the cause. I use also confocal microscopy. I use corneal swab, ocular surface swab, and then I use, of course, depends if I have a bacterial, if I have fungal, if I have viral. I use antiviral, I use antifungal, I use antibiotics, I use steroids. So depends on the cause of the infectious keratitis, of course. It is very important to understand the cause early, because you can target your therapy to the cause. And it is very useful to do a swab, to do also a microbiological culture of the contact lens, of the bandage contact lens. And also, if possible, to do confocal microscopy is very useful for differential diagnosis.
Thank you, Cosmo, so much. I think we have a lot of questions. It's going to be from the audience. We are going now to Miguel, my friend since many years. He's going to talk about surface ablation. most of us say that surface ablation is the safest and does not have any complication, and it's non-touch technique, and if you do it, you are safe from everything. But I think, Miguel, we are going to talk about if there is sometimes can happen negative feedback from this procedure or not.
Okay, so thank you, Ashraf, for the invite in this meeting. And as you say, that the PRK is in our mind one of the safest techniques. And in my talk, I will go on the not only to talk about the of some complication that are really few, usually regarding the AIDS, or usually regarding the correct not reaching the emetropia. But I will also show you how to use the PRK to cover the complication of PRK itself, and also to cover the complication of other kind of refractive surgery that to do some kind of complication on the cornea. So I will talk about the complex cases, and as Cosimo said, the more the knowledge and the better the strategy. So you have always to think about the original pathology and the cause of a corneal scarring, that is the most common causes of a corneal refractive complication after PRK, but also after transplant surgery and also after infection. And you have always to match the patient expectation and the real life target. And sometimes you have to aim more at the corneal surface regularization more than pure refractive surgery. And the improving the quality of vision in corneal complication does not mean to reduce the need for glasses. And remember, if you do PRK, you can fix just 1/3 anterior corneal problems, not more deep. So when you have a PRK complication or other corneal surgery complication, the first things that you have to do is to establish that if you have an unstable cornea or a stable cornea. Usually, the most common causes complication of PRK is corneal AIDS, but sometimes you have a corneal AIDS that is just due to the PRK surgery, but sometimes the AIDS is due to, for example, to a reactivation of a herpes virus after PRK. The other complication that is very frequently, especially with a patient who was operated with a very, very old laser machine, are decentration. And we can see this in PRK, but also in Lasik. And the other complication is the uneven ablation. For example, if you leave a wet surface, so you do a masking when you are performing PRK. The other problem of PRK is that you can induce a post-surgical ectasia, or if you do not have the knowledge of Renato Ambrosio about ectasia, you can also sometimes do a PRK on a cornea with a form frustrated keratoconus or with a pellucid marginal degeneration. So you have first to understand the causes. And then when you are here to fight versus a PRK complication, like for example a scarring, you have to know your weapons. So as we know, calcified lesion may have a lower ablation rate than the corneal stroma. So you have to consider this when you have a PRK complication. And if you use also masking fluids, you have to know the composition of this masking fluid, because it really affects your ablation. And you have also to consider for lengthy treatment that corneal dehydration is very important, because it may influence ablation rates. So this is a typical complication of a patient who was treated with an old laser. And as you can see, he has a corneal decentration. And what I do in this case is to retreat this patient with a topo-guided PRK, just to center the new ablation and to enlarge the optic zone, because this patient have a lot of night halos. So in these cases, the patient for this he had also a regression. It was a -5. So in these cases, I prefer to save some tissue and target the refraction to -2, just to save more tissue, because in these cases the patient was over 40. So in these cases, the -2 allows me to save the tissue and also to have a good near vision. And after this, after this treatment, the final visual acuity was 910 with a -1.115 sphere. The new optic zone is 7 millimeter with a transition to 8.5 millimeters, and no night glare and no need for near glasses. This is another case in which not only was decentered, but I have also some scarring. This patient was treated with an old laser. In these cases, also the topo-guided trans-PRK allowed me to enlarge the optic zone and also to have an asymmetric ablation who did the cornea now very even. And this is also how to manage refractive complication, but from PK. In this case, you can see a very irregular astigmatism, in which I use trans-PRK to regularize the cornea, and also to make as a final result a very good regular astigmatism, which I can easily correct also with the glasses or with the contact lenses. So you can use also PRK for managing the complication from other surgery like PK. This is another cases in which was performed a PK, then another colleague performed a PRK, but the final result was with the dense scarring. So in these cases, I retreat the patient with a topo-guided trans-PRK, but in these cases, I use also, after the initial trans-PRK, 20 micron of a dry PTK. That is a technique that I use very much to smoothen the stromal bed after the first trans-PRK. And as you can see, I have a beautiful result and a very regular astigmatism and just some residual scarring of about 10 micron. And this is important because now the patient can see very well, and these residual stromal scar do not really affect the visual acuity. This is another case in which I managed a scarring post-PRK, post-penetrating keratoplasty with a trans-PRK. And I will also show you another cases in which the patient have a refractive problem because he did a conductive keratoplasty 15 years before, and it was a 2.50 hyperopic. In these cases, I performed a trans-PRK inside the corneal scarring, inside the optic zone. And so the message is that you can use PRK also to, in these cases of conductive keratoplasty without any problem. Just plan the PRK inside the treatment. And this is the master key for managing all the complication from PRK and also consider all that kind of scar, that is PTK for corneal opacity. When and why? So you can use PTK to correct your corneal refractive problems if the pathology regards the first 1/3 of the cornea. And the other things that you have to think to yourself, if the patient have a visual problem just for the cornea, because sometimes you correct the cornea, but you didn't see what the patient have in posterior. So if sometimes I saw a lot of patients who was corrected for cornea, but they have some retinal problem. So they are not happy because the cornea was good, but they have a very bad retinal problem. OCT really helped you a lot to localize your enemy. You can see, for example, a scarring, a dense scarring after a PRK in the upper image. And with OCT, you can easily plan your surgical strategy. Look at this. This is a post-PRK corneal scarring. Is a very dense plaque, more than 180 micron plaque. In these cases, the patient was referred to me, but he was already scheduled for a SALC. And in these cases, what I did was a manual removal of the scarring, because in these cases is a mostly epithelial nodular scar and an uneven epithelial thickness, and the central scar was less prominent respect to the periphery. So my surgery planning was a manual epithelial removal, alcohol assisted, a 40 micron of dry PTK, and after a 30 micron of masking fluid PTK, so a smoothing. And this is the result. As you can see, the cornea is very clear, because in these cases, most of the scarring was nodular. So you have a lot of normal corneal thickness that you can use for PTK. In this case, it's just the manual removal of the scar was very effective in solving these cases. And this is a case of infection after PRK from Acanthamoeba, because probably due to the contact lens wear after the PRK treatment. And in this case, you have a very dense nodular scar, more than 140 micron. And in these cases, the patient was scheduled for DALC, but the patient refused this kind of surgery and comes to me, and I try to smooth the cornea as much as I can. And in these cases, my surgery planning was a manual epithelial removal, 50 micron of dry PTK and 30 micron of masking fluid PTK, and this is the result. I didn't remove all the stromal scar. I have now a 40 micron of a central stromal scar residual, but it is very, very even. So the patient have for sure a loss of a contrast sensitivity, but he can see at least 9/10 with no chases. So now he's very happy and without dark. So sometimes removal of all the scar is not the key. If you cannot remove all, just try to make the scar more even, and sometimes it is very useful also for the patient. And this is another cases, but this is a scarring due to radial keratotomy. In these cases, you have a central fibrotic scar, and I planned a PTK with a large zone, 8 millimeter of optic zone, and I planned a manual removal of this fibrosis. And then 30 micron of dry PTK and 30 micron of masking fluid PTK. And I will show you the video. In these cases, I use alcohol-assisted epithelial removal because trans PTK was not possible because of dense scarring. So I manually removed also with a normal device, with a normal device, the scarring and the epithelium that was very, very sticky. And then I performed dry PTK and also wet PTK. And at the end of the study, you can see the cornea with the contact lenses just after the surgery. And now was very, very clear. And look at the eyes, it was beautiful. And now the patient can see very well 9/10 with the notice and with a very small refraction error. So the managing of PRK complication and also of complex cases, this is my take-home message. So while there is enough residual cornea, there is a hope and no need for corneal transplant. So the knowledge of pathology, the laser system, and careful planning by clinical evaluation and imaging are the key of success. And you have always to consider a multi-step treatment. It's the first attempt to manage the refractive complication is not sufficient. And you have always the second option, that is the corneal transplant. So thank you for your attention.
Thank you, Miguel. It's a very nice illustrative presentation, but one of your cases I'm going to ask you about. It was a Canthamoeba, and you did a manual removal of the epithelium, then you did a dry PTK twice.
Yes.
You don't fear that the infection can flare up with the laser beams?
This is a case of 10 years old Acanthamoeba. So for sure, in these cases, the patient was treated also for with a PHMB and also with a iodopovidine, diluted iodopovidine for weeks after the treatment. So this is a limited case, Ashraf. This patient was really scheduled for corneal transplant. That was always my second option, but it was very, very feared. So the patient was conscious about the risk, but the risk was the same that he was scheduled to, so the corneal transplant. So this is not a normal surgery. This is a limit surgery. So in these cases, I take the risk because the patient was aware of. But finally, he was very happy. So you have always to manage this like a limited cases, but sometimes you can manage, and this is the proof.
Do you feel change? Do you feel in the results post-operatively?
Yeah.
When you do a manual removal with the alcohol, the PRK and the trans-PRK or the streamlight, you feel any difference in the outcome?
Yes.
The patient satisfaction, the patient pain, and why?
Absolutely different. In normal cases, now I just perform trans-PRK. I really abandoned the alcohol for a lot of reasons. If the patient moves, we have a lot of inflammation because the alcohol goes everywhere. The epithelium and also the stroma suffer. The other thing is that you can be very, 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 very clever, but the margin of the epithelialization are not even with alcohol, and are very square with the laser. So sometimes if you do an 8 millimeter optic zone with the trans-PRK, after 3 days, they're completely reepithelialized. With alcohol, you have to wait 4 to 5 days and much less inflammation with the laser. So in my advice, when you can, always perform trans-PRK. But when you have an AIDS, when you have a scar, trans-PRK is you cannot calculate. So I prefer to do it manually in these cases, and after smooth the cornea with PTK. So you have to think at the origin of the scar, the origin of the AIDS, and then adapt. But if you have a very faint AIDS, you can do trans-PRK or PTK without any problem, because the ablation rate will not be very different for a normal cornea.
Tariq, you have
I have a comment actually, because you already mentioned that in your presentation, that sometimes you're not able to remove the whole opacity, but you are regularizing the cornea. And I always say that the visual acuity of the patient may be reduced because of the irregularity of the cornea rather than the opacity. Maybe we have seen so many patients with very faint opacity. You can detect on the slit lamp, but the patient still can see. Of course, the contrast is not the best, but still can see. Sometimes if you remove the superficial opacity and some sort of regularization of the cornea, the patient can correct with glasses, even there is still remaining opacity on the cornea. And the visual acuity at the end of the day is much better than going for keratoplasty, even if you're going for DALC or something like this.
Absolutely. I do always the example of the sunglasses, okay? Mm-hmm. If you leave some regular aids, you'll have a contrast of contrast sensitivity loss, but the patient can see. If you have a tempered glass or irregular corneas, the patient can see very bad. So point at the regularity more to remove all the scar. This is the point.
Yeah, exactly.
Okay, it's my turn.
Okay, I'm the co-moderator, so I'm going to present my friend, Professor Ashraf Armian. Is the master of webinar, as I defined it before, and is a very, very focused now on education with also his school, the Otoa school, and now he's going to present the managing of complication in Lasik. So please, Ashraf, start the show.
Thank you, Miguel, and thanks for everyone who are sharing as a panelist in this webinar. I think it's very beneficial for everyone doing refractive surgery all over the world. So in my talk, I'm going to talk about the management of Lasik, either it's microkeratoma or femto-Lasik, challenging either intraoperative or post-operative cases. So, before we start, you must know what is the ideal flap. It must be large to cover the ablation zone and safety margin. It must be small, not to involve limbal stem cells and vessels. It must be thick to allow proper lifting and reposition without tearing or folding. It must be thin, safe on stromal tissue and strength. It must be stable to make the stromal tissue bridges hinge to avoid movement or loss of flap. The ideal flap, it's about 9 millimeter in diameter and 100 micron thick to cover the ablation zone and safety margin. It's rounded until 4 millimeter wide, superior or nasal hinge. The difference in flap from both methods, that the femto laser flap has almost vertical peripheral cut borders, but in the microkeratome, it's a gradually deepening. And the tissue bridges still connect the flap to the stromal blade and should be separated manually. This is the ideal flap. First, I'm going to talk about the irregular flap. Any irregular flap is caused either by technical failure or human error of choosing the correct cutting parameters. The problem caused by loss of fixation between the eye and the suction ring due to vacuum loss or unwanted movement of the patient. It's a mechanical stop, like the mechanical stop or obstruction of the motor. Blunt or damaged blades. It's maybe an old blade or it's not a good blade, or misalignment of the flattening plate. Or there is a tapering air or foreign body substance in the interface. Or it's an expansion of the gas bubbles performed by the femtolaser. Or there is an existing corneal scar and opacities, or previous corneal cuts, as in cases of previous Lasik, keratotomy, corneal inflammation. But in these cases, microtome is recommended and contraindicated to do a femtolasic flap, because the femtolaser may pass in the clear cornea to focus or the intended raster depths. It may pass into the clear cornea. Very important to know that the human error may cause mistake in matching the correct ring or the underlying shape. It's a mistake in defining the femtolasic parameters also for special cornea. What's the type of malformation of the flap? You may have a problem like small flap, which is defined as smaller than 7 millimeters in diameter and does not cover the entire intended ablation zone. Or it's a decentered flap, which means it's not co-centered. It's typically temporal decentration of the flap. And usually the pupil, centrally lays little bit nasally to the geometric center. The correct flap, you must know that the correct flap must be large enough to exclude its hinge from the ablation zone and to allow some playroom for mild decentration. It may be a incomplete flap, which is the flap during the microkeratome. It stopped too early, so it is incomplete flap. But take care, you can convert it to free incomplete flap when you elevate it. Free flap, it's a complete full circle of the flap. The hinge passes, there is no hinge, and you perform a free cap due to the microkeratome. It may be more worth. It's a torn flap, and it's more common to happen in the cut into 2 or more parts, not connected, due to vacuum ring losses while the motor is continuing. The femtolasic flap is more prone to flap tear than the microkeratome, because there is a thinner flap in the femtolasic compared to the microkeratome. Usually it happens if it's a very flat corneas less than 42 diopters. Another problem can happen is the buttonhole flap. The buttonhole can happen in the microkeratome and also in the femtolasic. It's a hole. It's a full buttonhole due to the full flap thickness, or through the stroma or Bowman's membrane only, and it leads to imminent or occult buttonhole. In the femtolasic, in the blade when the blade with the vacuum loss, it can goes under the corneal surface and by the vacuum loss, and do this in the microkeratome. But in the femtolasic, the bubbles can expand, penetrating through the weak point of the underlying flap and lead to vertical gas breakthrough. Very important to know that a buttonhole within the optical zone is much worse than a hole outside the ablation zone. And the risk for buttonhole is higher when the flap is less than 100 micron flaps. You can face in femtolasic a sign called opaque bubble layer, which is the OBL. It's due to the occurs when the raster energy is too high, producing excessive gas, or when the venting pocket, the canal, is not open enough. This alternatively these bubbles either go under through the very thin flap and cause a buttonhole, or go penetrate into the stromal bed to the anterior chamber and do a cavitation bubbles, which is we don't like this cavitation bubbles during the laser treatment, because the cavitation bubbles obscuring the tracking of the pupil and the iris reference points. So how to avoid flap malformation? Again, since the flap malformation is caused by mechanical failure or human error of the surgeon, it may be minimized by a through standard pre-check of your data and instruments. Very important when you check your instrument to avoid these malformations, avoid LASIK in high risk, like the cornea is smaller than 11 millimeter, flatter than 38 diopters, or steeper more than 50 diopters, because this is has the high risk of vacuum loss and flap malformations. Very important to use the correct vacuum ring docking size of the corneal keratometry and the hinge size according to the manufacturer's structures. I highlighted in red, which is very important in any microkeratome LASIK surgery. Use color marking on the mid-peripheral cornea that will guide you to reposition the flap in cases of torn or free cap. Very important to assure that your clear interface. Very important to check your lid opening, the eyelashes, the lid gland extension. How to check your vacuum? There is 5 signs to check that you are in a good vacuum before you have your motor or the laser appear. The eye must be pulled with the vacuum ring without losing the vacuum. The vacuum negative pressure is constant and in the manufacturer range. The eye pressure is high. The patient report that there is loss of vision during the suction and the pupil does not react to light. At this point, you should warn your patient, we are going to start, you must be calm. And you must follow the cutting carefully under the microscope to detect the abnormalities as early as possible. Very important between yourself that you should, the first step in treating any flap malformation is to diagnose its extent. Very important to know that if you ignore this, you are going to fear more, you are going to have more complications. I'm going to put the complication and the management. So if you have a buttonhole or a flap tear or missing hinge, first discovered usually when you start to elevate your flap, you are going to face the complication. Once you find this, the femtolasic flap should not be lifted and the excimer ablation should be aborted. And you leave the patient, because you didn't destruct any tissue bridges, leave it to heal and see what you are going to do. Another problem, if you have multiple raster passes, does not cause irregular stromal bed or intersection of the cutting planes, and may be consequently attempt. So if the suction fails, again, you put the suction, fails again, or the overlying epithelium starting to lose its integrity, the procedure should be aborted. After a few weeks later, recut or surface ablation technique may be attempted. Recut in a deeper plane, which is it will be more safe for the patients. Another problem, if you have a dense opaque bubble layer, OPL very dense, so don't go, stop, leave the patient for more than 30 minutes. The gas bubble will be absorbed spontaneously, clear cornea will going to appear, the pupil view, allow flap dissection, and the excimer laser is planned. Another problem, Very important to diagnose the free flap. The free flap is easy to be identified as a stromal bed is bare, and the flap hides somewhere in the microkeratome as in the picture. But the very experienced surgeon can notice a buttonhole without lifting the flap, as it is evidence of shiny island on the stroma indicates Bowman's membrane perforation and an imminent buttonhole. How to manage? Reposition the flap in its original anatomical form and position. Don't do much manipulation, as less manipulation as you can. Don't put much water, don't rinse too much BSS, and don't move the tissue too much not to make more damage. Usually stabilize the flap by allowing dry imposition and protect with the therapeutic contact lenses. For sure, excimer ablation should be aborted for a later time. What about free flap? Free flap is expected when the hinge of the regular size and position and is properly marked. The ablation may take place as originally. Because it's a free flap, no problem that you elevate the flap, you have your marking, start your ablation normally, and re-put the free cap according to the marking you did, dry, put a contact lens. But very important, if you feel that the stability of the free flap is not good, take a corneal suture, it's not a shame, as an artificial hinge. Some rules I'm going to say. Rule of the thumb, the cutting plane of a regular flap is per definition contraindicated for an excimer ablation. Also, removing the epithelium before surface ablation should be done very gently to avoid the reopening of the irregular flap interface in cases of complicated complication happened before in the previous procedure. When you remove your epithelium, avoid mechanical alcohol assisted. Use an excimer laser PTK to remove the epithelium. Use the non-touch technique, then you do the refractive PRK. And for sure, Mitomycin 0.02% applied for 30 to 40 seconds to avoid additional haze. Another last problem I'm going to mention is the epithelial erosion and how to manage. It can happen when the flap creation caused by pressure of the applanation of the femtolaser plate cone, or friction of the microkeratome over the cornea, or scratching the cornea by the lid opening. Marking tools may be aggressive, or who are repositioning an edematous flap. Also, there is some cases prone that epithelium can be happened, like this, erosion. In cases of epithelial basal membrane dystrophy or recurrent erosion syndrome, in cases of severe dry eye and also excessive use of local anesthesia, non-cooperative patients, deep set eyes, and narrow lid opening. To reduce the risk, rinse before you put your femtolaser cone with the BSS. Normally, the epithelial erosions, if it's small and there is no precondition, make the patient susceptible to epithelial erosion, usually it go clearly permanent effect with the results, what does not affect the result of the Lasik. But in some cases, epithelial erosion in the flap center had thickness of about half of the flap thickness and may cause post-operatively flap stria, DLK, and stromal haze. In dry eyes and basal membrane dystrophy, erosion may evolve to persistent epithelial erosion and can lead to recurrent erosion syndrome. So my home take message, very important in any refractive surgery. Do not hesitate to consult colleagues who are cooperative and may have more experience than you, or a technical means such as topography-based ablation to help you in any difficult situation in refractive surgery. These are my reference. Thank you so much. Miguel.
Okay, I was searching for unmute. So thank you, Ashraf. I think that femtolaser really helped us to keep our surgery more safe. Do you think that actually the microkeratom Lasik has still a role? Because in the recent times, I saw a new blade from a French company, not to mention it, that they marketize as the easy and no very low complications, also with the microkeratom. Do you think that there is still a role for blade Lasik now? Also for the cost, I mentioned especially for the cost of the surgery.
For me, I stopped the microkeratom since 2015. I didn't do any case since 2015 till now, except one case only, because I feel that the safety measures that gives by the femto Lasik is more than any cost the patient will going to give, because the complication of microkeratom, if happens, it can lead to disasters in a patient. He's seeing well, perfect with glasses or contact lens, and he's seeking the same results with the refractive surgery.
Another question that sometimes we do not take care of. How much is important the micro environment of the operation theater in laser?
Yes.
Laser. Yeah.
This is very important. You know that all the area of the theater of the refractive surgery have an air condition.
Yeah.
And in some centers, they noted that when the air condition or the ventilation in the rooms are not equally distributed, they found that the refraction results in one eye is different than the other eye due to the air current in the operation theater affect the laser ablation settings to the strobe.
Yeah.
And we found this since many years in our center at Al-Watani Eye Hospital, because it was not centrally have the same current. And we noted this problem that the right eye different than the post-operative result of the left eye.
Yeah.
And we noted this problem and we managed it in the last years, because we didn't know why the left eye is always not a good post-operative correction.
Yeah, I provoked you about this because I have some experience with a femto laser, and I noticed that when I was in an operation theater in which the microenvironment was not even, sometimes I have a lot of gas bubbles, more than my normal activity. And when I switch in a new operation theater in which the microenvironment was quite the same because air conditioned was always open, I didn't have this problem. So I think also as a refractive surgeon, refractive surgeon, we have to take care also about these details. Yes. It is always under-evaluated.
So now I can represent Dr. Eric Martins, one of the eminent in refractive surgery and in ICL tools, either sizing, surgery, or how to deal with the challenging situations post ICL cases. So he's going to talk about how to manage challenging situations using the ICL as a refractive procedure for refractive patients. Eric?
Thank you, Ashraf, for your kind invitation. I'm going to share my screen now. All right. Okay, here it comes. So I want to talk today to you about optimizing results in refractive surgery and specifically fake IOL implant. I'm a consultant for Star Surgical. This is my financial disclosure for this talk. What are the tips and tricks I can share with you to optimize results? We're gonna cover a lot of topics, and I will have to. I cannot dig deep into all of them, but I want to highlight a few of them. So first of all, we're going to talk about under and over correction, because when you do a pre-op measurement, it's of the utmost importance that you do a perfect refraction. I always use the same optometrist doing my refraction. I taught him how to do it, and my calculation of the ICL is based on this. But there are other issues here, because when you have dry eyes, this can influence not only the keratometry readings and the astigmatism, but also the refraction. And so we take great care in diagnosing dry eyes and manage them. So we treat them and we let the patient come back after 3-4 weeks until we get a good non-invasive break-up time before doing a refraction and before ordering the ICL, because this is a key component in avoiding problems after surgery. So I also use this is the MS39 from CSO. I do corneal topography. We look at the anterior and the posterior elevation and the corneal thickness, of course. This instrument also gives us the anterior chamber depth from the endothelium. And this is a very important button here. This is, when you click on it, you get the epithelial thickness. Because when the epithelial thickness map is not evenly distributed, thickness is not evenly distributed over the cornea, also you have to look for like basement membrane dystrophy and treat it before you do good refraction and ordering the ICL. And you can rule out a lot of inconsistencies in your surgical results. Mm-hmm. These are my cases in well, about 1,500 V4C cases and a follow-up in 306 eyes with more than 3 years. You can see that it is a very good correlation between the attempted and targeted refraction. You see all of the cases are within 1 diopter of the attempted refraction, and the calculated R square is 0.999. So it's one is ideal, of course, which is in the real world not possible, but we try to get as good as possible with this. And this is due to taking care of the cornea, getting the cornea in shape before ordering the ICL. Now, what about low volt and high volt? There are a lot of discussions about it, how to deal with it, how to do it. And I will share with you my tips and tricks. Again, I'm using the OCT MS39 from CSO, and it does a lot of things. But for ICL surgery, anterior chamber measurements, and dry eye film analysis, as I already pointed out, are the ones I'm looking into this machine. How this small picture shows you where the measurement was taken, so in a horizontal axis. And what we're looking for is a scleral spur. The machine itself gives you already the scleral spur, and look at it when it's in the right position. And in more than 90% of cases, the machine already detects the perfect spot where the scleral spur is. And it also gives you measurement for you, and you just have to read it from the machine. We put it in the equation formula of Nakamura. It's not the same one I'm using here, but it's based on the Nakamura formula, but optimized for the MS39. And so this is the formula. We put in the scleral spur to scleral spur measurement and the lens rise, which is also the data given by the OCT. And when we do the calculation in this eye, we get in 12.62 and we ordered in this case a 12.6 millimeter ICL, and this is preferred. So, and these are the results with this formula. You can see the purple bar is giving me the 12-month post-op results, and all of the eyes are within 100 microns and below 1,000 microns of vault. I must point out here that with the introduction of the Aquaport, so the version V4C in 2011, already 9 years ago, I found out that a low vault is not an issue anymore. We don't get cataract formation, and this is one of the points I'm going to discuss later on. But don't be afraid for low vault. The only issue with the version V4C and later versions like the V5 is higher vault and possibility of angle closure glaucoma, which of course we need to avoid. When dealing with intraocular surgery, always the risk is of endophthalmitis, and we want to avoid it as much as possible. This is published in the peer review literature in 2009 already, with about 18,000 eyes, and only 3 eyes were reported with endophthalmitis, and 2 of the eyes with follow-up, and it was in both eyes, Staphylococcus epidermidis was the bacteria causing the endophthalmitis, and with full recovery. As you know, we don't have to exchange the crystalline lens in these cases, and it acts actually as a barrier between the anterior chamber and the posterior chamber. And that's why endophthalmitis in phakic IOL implantation, you don't have to fear that much as with refractive lens chain of cataract surgery, because you don't have that rapid exchange of organisms in between the anterior chamber and the posterior chamber. So this is the reason why this is not so devastating as in lens or cataract surgery. And prevention, of course, is the way to go. How do we do it in our center? So we use 10% povidone iodine and 5% on the ocular surface, 15 minutes and 3 minutes before surgery. And immediately after the surgery, we put 1 drop in each eye of povidone iodine 5%. Also, minimizing the incisions in the eye is important. I only use 1 paracentesis close to the distal haptics and 1 3-step main incision of 2.6 millimeters. Why 3 steps? Because it's nicely self-sealing. You don't have to put a suture, and we don't have problems afterwards. The surgery itself takes in most cases less than 2 minutes. And as pointed out by the ESCRS, the large trial with cefuroxime, I use 0.1 cc intracamally of cefuroxime to prevent endophthalmitis. I already touched the subject a little bit in my previous points, and I'm going to talk about increased intraocular pressure. With the introduction of the V4C and the V5, so we call it the Aquaport, which is the central hole here, the 360 micron central hole. We have never seen pressure spikes anymore since 9 years. Of course, we take great care in preventing it by giving 250 milligram acetazolamide 1 hour before surgery, immediately after surgery, and we give 1 tablet with the patient when he goes home, and he has to take it with the next meal. During that meal, he takes the tablet. I let the patient stay in the clinic for 1 hour, and we check the intraocular pressure then. I'm using only methylcellulose, no other kind of viscoelastic, no other kind of hyaluronic acid, because even when you leave some methylcellulose in the eye or in between the ICL and the crystalline lens, it flushes out, and it flushes out much more easily when you do not constrict the pupil with myotic agents. So I would recommend you never to use myotic agents. I've never used it in my 20 years of ICL surgery, and I never had a problem of the ICL popping into the anterior chamber after surgery, so you don't have to be afraid that it happens. And this also not only pointed out by me, but also by Mark Packer when he did this meta-analysis and published it 4 years ago in Clinical Ophthalmology. He reviewed a lot of studies, and he also in other centers, they were not seeing pressure spikes in these cases. What about repositioning or removal of the ICL? In this case, in high volt, as I told you, Sometimes there can be a closure of the angle here. So, and this is the judgment of the patient, of the surgeon, of course, after surgery, whether to exchange this lens or have a review of the patient regularly and then see whether this fault is acceptable in this eye. So this is in the discretion and the knowledge and the experience of the surgeon to follow it up or exchange the lens for a smaller size. This particular case was published in a book by CSO, and you see a very peculiar here bulging forward of the iris here. So what happens when we do a magnification of the center part here, you will see what it is. It is an insertion of the ICL upside down. Of course, this is a surgeon not taking attention of where the holes in the haptics are. So when you introduce the lens, you can see it immediately that the hole is in the wrong position, and you don't go further, so stopped surgery. But in this case, the surgeon went on, and the ICL was delivered upside down in the eye. The surgeon did not notice it. He noticed it the day afterwards with, well, very peculiar refraction with hyperopia and astigmatism. And only by doing the OCT, he found out that the ICL was upside down. Of course, then you have to exchange the ICL, and I will share with you my technique here. This is here again, me performing the 3-step main incision, the 2.6 millimeter. I already introduced, as you could see, the methylcellulose. This is, I already did it before through the paracentesis, which is here. So I go in with this suited instrument, and I put the haptics in front of the iris, as you can see here. I try just not to touch the optic zone, just here at the rim and the haptics as well. Then I go under the ICL. I go a little bit upward, and I pull the ICL out the eye. I refill with methylcellulose, and I introduce the new ICL. So it's a very elegant method, and it works in all cases very elegantly in, let's say, 1 to 2 minutes surgery. Another possible problem is damage to crystalline lens. So you as a surgeon has to avoid it. I already gave away the take-home message. So do not touch the ICL through the optic zone because it's the thinnest part. Only touch the ICL on the rim or on the haptics and avoid the central part of the crystalline lens. So you cannot damage the crystalline lens. Of course, this then you are in real problem when you penetrate the anterior capsule. You have to convert to lens extraction, which of course is difficult to explain to a patient afterwards. What about halos, glare, and double vision? Here in the recent model, the V5, which was introduced a couple of years ago, you can see here that the V4C, a -9, has an optic zone in the ICL of 5.8. And in the newer version, it is 6.1 millimeter. This is the schematic diagram of the V4C. This is one of the V5. And the only difference, there is no change in overall height. No, the only difference is here, the rim size. The rim is much smaller in the V5. So the company could manage to deliver a larger optic zone. And this is the V4C in the eye and the V5 in the eye, the same. You can appreciate the rim, smaller in the V5, larger in the V4C. And these are the same lenses outside of the vial, the same thing. So when you look at the overall myopia from -9.25 to -0.5, the optical zone size was increased from 5.8 to 6.1. And bear in mind that 6.1 optical zone ICL gives you 1.24 times on average, because this is dependent on the anterior chamber depth on the cornea. So you're dealing here with a more than 8 millimeter optical zone on the cornea, which is of course very acceptable. When going down in of higher myopes, the optical zone size of course diminishes, because of when you have a higher ICL diopter, the rim is thicker, so there is a limitation in what we can put in the eye. So the distance between the ICL and the cornea is not getting too small. We looked at the quality of the EVO plus ICL with the eye trace. As you can see, higher order aberrations, circle aberrations, secondary astigmatism, trefoil, very low in these lenses. What about cataract development? I already told you that with the introduction of the aquaport, I see lower volt as well. I'm following for the moment 23 eyes with a volt of less than 100 micron and a follow-up of more than 4 years in all of those 23 eyes. I do not see changes in the lens, in the natural lens. Not seeing anterior opacities, which we saw in the previous versions, so the V4 and the previous versions with no aquaport, which proves that by forcing the aqueous in between the crystalline lens and the ICL before going into anterior chamber, it's very important to bring the nutrients to the anterior surface of the crystalline lens, which prevents cataract development. Of course, they will get cataract because some eyes are high myopes, and we all know they get sooner cataract. But with the newer versions of ICL, I don't see sooner cataract formation than without ICL surgery. And then last topic, but which will be covered in depth in the upcoming presentation, but very quickly, do a thorough vitreoretinal examination. It is essential. And in my opinion, you have to mention this in your informed consent. Do a retinal examination by OCT, and you can look at, of course, these are pre-op wet macular degeneration, which you do not see that much in, of course, younger patients, but you can see it sometimes. And here there is a traction, vitreoretinal traction on the fovea, as you can see here. Just do the examination with the OCT, so you can afterwards, it will prevent post-op headaches, because you can prove to the patient this was already your retinal status before surgery. And do it with an indirect ophthalmoscopy. It should be the standard of care. Do a prophylactic laser coagulation when you have superior round holes without PVD. And of course, horseshoe retinal shoes of tears always need to be treated. And I sent them to my retinal specialist. I don't do it myself. And I think everyone has his own specialty. So this is very important. So in conclusion, I can say, as with any surgery, avoid complications. And how do you do it? By careful preoperative planning. And in these post-COVID times, we more and more do immediate bilateral sequential. Why? Because we diminish the amount of visits in the clinic, which is much appreciated by the patients. Of course, we always leave them possibility to have both eyes done at a separate day of surgery, but more and more they want to have the immediate bilateral sequential surgery because of, they appreciate that we offer this opportunity so that they can have less visits in our office because of the post-COVID-19 issues. So this will be, in my opinion, the new normal. I thank you very much for your kind attention.
Thank you, Eric. It's a very elegant presentation. And I like it the way you remove the ICL from the eye. Is it easy like this, that first do you inject OVD under the IOL, or you don't inject?
Yes,
and yes, and how and you just elevate the ICL and make it touching the lip of the wound and act as a pivot, so you remove it like this.
Perfect. Exactly. Yes.
Okay.
Yes. You explained it perfectly, Ashraf.
Yeah, this is the way. Okay, and there is questions from the audience, which is a very important questions, and everyone is asking all over the world. Hypermetropia, ICL, when we are going to use it for safe, because we are reaching, have a lot of hypermetropia patients in young age, and they want to be like the myopia. What do you think about ICL and hypermetropia? And can you stop sharing the screen?
Okay, let me stop sharing the screen first. Okay, so hyperopia, yes. The main problem is anterior chamber depth, of course. You need, although the labeling is 3 millimeters of anterior chamber depth from the endothelium to the anterior surface of the crystalline lens,
I go as low as 2.8. But still, then the amount of young hyperopes with an anterior chamber depth of 2.8 and larger is limited, as you know. So unfortunately, we have to turn down those patients, or when they're old enough, we can do a refractive lens exchange. But yeah, this is the limitation of hyperopic correction with the ICL. I know, but it is the way it is. We have anatomical restrictions, and we need to, of course, take this into account.
What's your experience on hyperopia?
Well, very good. When I have 2.8 millimeters or higher, and I have a nice angle opening, a nice open angle, I will put in an ICL, no problem. And they react very well. Of course, the pre-op refraction is a little bit more tricky. I always do a cycloplegic refraction when they're very young, and try to, then I get them back in the office a week later approximately, and I try to push them as much in the hyperopia as possible to get the maximum out of my ICL implantation, but do not overcorrect, because when they end up in myopia, they're not happy as well. So you have to talk a lot more to hyperopes and tell them, okay, you still have we will have a latent hyperopia. You will be good for many years, but bear in mind, maybe in 10, 15 years, you will end up with a +1 or a +1.5 diopter, but you can still then exchange the hyperopic ICL with another power, because this is the beauty, of course, of the ICL. It's reversible, or when they're old enough, of course, you can do a refractive lens exchange as well.
What about ICL in children?
Well, a very good question. ICL in children, I did it in a few cases. I'm very high myopes. I already did it, and to lower the progression of the myopia, or in anisometropia. It works beautifully in anisometropia to take care of this, and then afterwards I can wear glasses or contact lenses, of course. But in anisometropia and to treat amblyopia in those cases, it works beautifully.
The last question: in the case you remove the ICL because it's upside down, do you put the same the same ICL, or you order another one?
This was not my case, by the way, but that doesn't matter. You just take out the ICL. Of course, when you tear it, then you have to use another one. But otherwise, you just reload it and you inject it in the anterior chamber in the right position. That's no issue at all.
Because you presented a very nice way, because it sometimes happens during surgery normally, and it's upside down, and you remove it in a very elegant way, and because it's going to be not cut like this, and you can put it again in the same way.
Yes, exactly, yes.
Thank you so much, Eric. It was a very nice, wonderful presentation.
Thank you, Ashraf. Thank you for this kind invitation.
Thank you so much. And now I'm going to present one of my eminent friends in refractive surgery. And I always say that he's the first one worldwide represented the case of post-Lasik ectasia femto smile. And every meeting or conference I go, they always put this paper and they say his name, Tara Nagar, the first one worldwide reported a case post-Lasik ectasia, post-smile. So Tara, he's going to talk about a very interesting topic, central toxic keratopathy. It can happen to any one of us. How to manage. Tara.
Thank you, Ashraf, for the invitation and for the nice introduction. Actually, it's not a funny topic or a nice topic to present, the central toxic keratopathy. Luckily, it's rare. But first of all, we should look into the nomenclature, because if we look at this surface, the keratopathy, it is not keratitis. If you ask any medical student what is the difference between opacity and itis, he would answer that if it is opacity, we actually don't know the main etiology. And this is not inflammatory in nature. And of course, the pathophysiology is not completely understood. And at the same time, we don't have a specific treatment. This is what meant by opacity, actually. It means a disease, it's not itis. So we should put this into our mind before we start. As I have a look on etiology, there are several theories regarding the etiology. No one of them is entirely right. but sometimes we say it's laser-induced keratocyte apoptosis of the corneal matrix. Some postulate that foreign material introduced under the flap, like bovidine iodine, which might be photoactivated by the excimer laser. The meibomian gland secretions, and I believe this is one of the main reasons that could lead to this sort of complication. The marking pen ink itself, it can cause DLK and can cause CTK also. A talc powder in the gloves, and the debris from the microkeratome blades. All these etiologies are purpose, but no one is entirely right. What about the pathophysiology? What we know that we are having a central cornea thinning or flattening. This degeneration occurs during the first week maximally, and followed by regeneration in the coming months. There are lots of stromal tissue, and the most accepted theory is because of the apoptosis of the keratocytes, or enzymatic degeneration because of the matrix metalloproteinase that may be there, and maybe combination of both theories. Other theories that keratinocytes injury might release cytokines, which cause change in the interstitial fluid pressure, which cause microedema and causing this opacity. Some believe that it is immunological process. This is the pathophysiology theories, but no one is entirely right. Let's have a look on the clinical picture that you might face. Here is the mild form of the CTK. You face an opacity, mainly central, as the name of the condition, with sharply delineated edge and some stray here. You can see this stray. This is one of the main features of the CTK. If you see this shape even for the first time in your life, you should suspect CTK. And this is the severe form of the CTK here to the left, to the right. And this is a famous picture of long-standing CTK by Mosherva. And let us look at the differential diagnosis. We have many cases that can have similar picture, like infectious keratitis, post-PRK haze, and DLK, and PESC, which is pressure-induced stromal keratitis, and other conditions like epithelial ingrowth and stuff like this. But the main debate here is the CTK and DLK, because some believe that the CTK is a stage 4 of the DLK, but this is not right. The CTK is now believed to be a separate entity. DLK occurs starting from the first day of the operation, while CTK can occur from 3 to 9 days after the initial surgery. What about steroids? We know that DLK is keratitis. Actually, it is steroid responsive, but in CTK, it is not responsive to steroids. Sometimes CTK comes with a degree of DLK, so steroids will treat the DLK, but not the CTK itself. What about the opacity shape? The opacity is widespread in DLK, while in CTK, it is confined to the central part and extended to the anterior and posterior stroma of the cornea. What about the examination? If you look at the slit lamp, there is no striae or refractive changes in DLK, but you have hyperopic shift and striae in the CTK. The prognosis, the DLK usually responds to steroids and resolves in a week, while CTK could take 2 years to have a good prognosis. The confocal microscopy shows in DLK no loss of keratocytes, while we have inflammatory cells. In the CTK, loss of keratocytes with no inflammatory cells present. CTK could occur after PRK, although fewer reports are there, but sometimes this is believed to occur after PRK, while mainly it occurs after LASIK. Of course, DLK occurs after LASIK only. Sorry. This is the difference between the DLK. You can see here the shape. The DLK has this opacities extended to the flap edges, while the DLK, the CTK is confined to the center with sharp edge here, with the dominant striae in the center. This is a patient of mine. I received her for consultation. In July 2017, he presented with dense CTK, and you can see here the refraction of this patient is hyperopic astigmatism, corrected to 2040. The unaided corrected visual acuity is 2200. After almost 2 years, the patient improved a lot, still has some hyperopic refraction, but correcting to 2025. What about the treatment? As we already said, we don't have a definite treatment, but reassurance is the main stage here. The reassurance for the surgeon himself and reassurance for the patient. We should tell the patient that this condition would last for a long time, but the end result will be good, fair to good. So he has to be patient and not to ask for more this time. But the things you should do is don't touch the flap. Don't lift the flap. Try to lift the flap. Don't treat the striae. Don't remove the epithelium in order to treat the striae. Don't irrigate under the flap. Don't scrap the stromal bed because the stromal bed might lose some tissue because of this scrapping. And do not use steroids. This is not, as we already said, inflammation. What you do for this patient, again, reassurance. You give him preservative-free lubricant to aid the epithelial remodeling and stroma remodeling. You can use matrix metalloproteinase inhibitors like doxycycline. I use it 100 milligrams twice a day for 1 month, followed by a lower dose 50 milligrams once daily for 2 months. And you can use vitamin C 1 gram. This is to help healing of the cornea. 1 gram per day. I can use it for 3 months at least, and follow up of the patient. The visual rehabilitation of this patient, because the patient suffering from hyperopia, which is very problematic for the patient, you start with glasses, or you may end up with rigid gas permeable lens for the period until improvement occurs. Flap lift and enhancements after 18 to 24 months if needed. And there are a lot of reports showing that there are no contraindication for relifting the flap, and the CTK doesn't recur after enhancement. Take home message again, this is a keratopathy, not keratitis. This is the main thing you should know about this condition. Don't use steroids, don't try to treat it aggressively, just wait until it improves by itself, and tell the patient he should wait for improvement. Thank you for your kind attention, and stay safe.
Thank you, Tariq, so much. It's a very debatable between CTK and DLK. Anyone can mistake easily. Just I want to tell you why this happened. Why CTK happened in a case of Lasik?
Well, we don't know actually, but maybe because of the laser activation of the keratocytes, which occurs rarely, luckily. Sometimes I believe it's because of my Bobian gland. I have one of my patients who is suffering from this CTK, and afterwards I examined the patient. He has a silent chalazion in her eyelid. Maybe this is a theory behind it. Maybe the meibomian gland itself, it activates the keratocytes, or leading to this opacity formation. But actually, we don't know. We don't know the exact cause. But there are a lot of theories, as you already mentioned. But we don't know exactly the reason.
Is it common to happen in a smile?
I don't think there is a case report related to smile, but because smile is using entirely femto laser, not excimer laser, and if many of the postulated theories are related to excimer laser itself, we don't know. But because the smile is still a young procedure, relatively young procedure, maybe later on we can see cases like this. But right now, I don't think there is a case report related to CTK. I know there are some DLKs reported already after smile, but no single case, I think, of CTK. If you can correct me if any case report, but I haven't seen.
No,
one.
I didn't hear it. Yeah.
No.
Ahmed.
Yes, question for Tara. Yes, how many cases you actually faced with this complication? Was it bilateral in the same patient, or was it only in one eye? And what do you think about the treatment? What's the prognosis for the patients? Do they develop haze or central opacity? How do you deal with the patients like this?
Well, actually, I have seen in my entire career 5 cases. One of mine and 2 cases referred to me bilaterally. The thing is, it is rare, and luckily it's rare. And I believe the management is just wait. The other drugs we use just to give the patient something to do. You know, matrix metalloproteinase inhibitors like doxycycline has a lot of side effects, especially gastric. But this is the only thing that you have. And of course, the preservative-free lubricant, you give the patient drops to use. But the thing is, don't use steroids, because sometimes you feel like it's in haze, like we already mentioned in PRK and with other condition with cross-linking. But the haze here is different, and using steroids will end up with elevated intraocular pressure that might lead to fluid in the interface. And I think there are a report of case with CTK reported to have an intraocular pressure of 40 after using steroids for a long time to treat CTK.
Cosimo.
Yes, I have two considerations. I think that in these cases, in the preoperative, we could use confocal microscopy is useful in the pre-op and also for the diagnosis. I think it is also another test that is the inflammatory test from RPS that could do a dosage in the tear film of the metalloproteinases 9 that could be useful in this patient. What do you think, Tarek?
Yeah, I totally agree with you, but using confocal microscopy for preoperative Lasik or refractive surgery case would be a burden for the patient and for the surgeon, because it's not available everywhere. But of course, if we have a confocal microscopy, it would be nice to detect stuff like this preoperatively. You know, for example, if we are talking about another issue like ectasia, we would like to have seen the Beryllium microscopy preoperatively for every patient who have ectasia right now. But this is not available everywhere. I think in Egypt it's available in just one place.
But what do you think? What do you think about the point of care test RPS for metalloproteinases in tear film?
I think this is the future. Testing the tear film preoperative for qualitative and quantitative thing is important, and even there are a lot of factors now to be detecting the ectasia even possibility now, and I think this is the future. And
yes,
but not widely available, but it's a good idea.
We have introduced the RPS test now for our cross-linking patients and refractive patients, because I think it's really important to know if there are some inflammatory process or if there is an imbalance between enzymes that could lead to stromal depauperation. Yes.
And I think the MMP now is believed to be one of the factors related to keratoconus. And even if we know and always know that keratoconus is not an inflammatory condition, and I believe it's clinically non-inflammatory, but on labs, it has some sort of inflammation.
Okay.
Thank you.
So I think we have to go, and I will present with my great pleasure Susan Jacob. It is the director of a refractive service in Agarwal Eye Hospital, and she will speak about the smile complication. And she's one of the first users in the world of this technology, and she has a lot of experience. And I hope just a few complications, but I'm sure that she managed it very well. So please, Susan, let's introduce your talk, and thank you to be here with us.
Thank you. Thanks so much, Miguel, for that introduction. I'm just going to start my presentation.
Yes.
Thank you, Ashraf, for inviting me here to this webinar. Like Miguel said, you have become the master of webinars, and I really enjoy all the ones you conduct.
Thank you so much.
So my talk is on smile, and I'm going to be showing a few of the complications that you can get after doing smile surgery. Generally, you get a very good result with smile, and I'm really very happy with the way the procedure works. But you also do need to know, as for any other procedure, the complications that you can get and that you should be aware of. So when you look at the complications, you can have lenticule-associated complications. And you can have these can further be classified as, for those that are associated with the creation of the lenticule, with the dissection of the lenticule, or with the extraction of the lenticule. So my talk is going to be video based. I'm going to show you some of the common problems that can happen. This is not to say that complications are common with smile. It is just that among the complications, these are some of the commoner ones that are seen. Most of them are managed well and easily. Here is a patient who had suction loss during lenticular cut. You can see that. And this is basically suction loss after smile. In all the situations, it can be managed with a recut, and there's a wizard there on the computer that tells you how to manage it. The only situation where you cannot and you have to convert into a Lasik with a femtoflap is when the lenticular cut has exceeded 10%. So here in this case, you can see that the lenticular cut had exceeded 10%. And so here what you do is you basically go ahead and convert this into a femtolasic flap. So you can see what we're doing is just cleaning up that cone a bit, and one of the causes for suction loss can be excess fluid, which prevents that vacuum from building up. You can see we're removing all the fluid from the conjunctival sac as well as from the cone. Reapplanate, we've used the same cone, and go ahead and create a femtolasic flap with this. So this was an interesting case because it shows the possibilities that can happen when you have this double dissection. So here you can see that what I'm doing is dissecting off or lifting up that femtolasic flap, and you can see that there's that area where both the previous dissection as well as the present dissection have kind of overlapped with each other, and there's that strip of tissue which is actually going between the two areas of dissection. So these are things that you have to be careful about, and this is also the reason that if the lenticular flap cut has exceeded more than 10%, you do need to convert into a femtolasic flap, because you wouldn't want such things happening over the pupillary axis. So here's another case where there's a suction loss during the cap cut, and you can see the lenticular side cut, the lenticular side cut all went smoothly, but then when the cap cut was there was a suction loss, and so it has been repeated again using the wizard, and then you go ahead and dissect as you would normally do. Here's a third case where there was a suction loss during incision, making there also some black spots there in this case, as you can see here, over there and there. And there's a suction loss before the incision could be completed, which means it did not cut through all the way through the epithelium. So a second incision was made, and then the case was proceeded with. Now, this case is really interesting. It's actually a case study in suction loss. This was a 23-year-old, very, very nervous patient, 110 kg, short neck, obese, and he kept moving around a lot. So you can see what's happening is that was even before anything was done, there was a suction loss. Then second thing, he had a suction loss. You can see that it's just before completion of the lenticular side cut. So there's that area that was uncut. There's definitely more than 10%. So the computer, the machine asks you whether you would like to restart, and then it basically keeps going into the next step. And here it tells you that you cannot continue as a flap, as a cap cut. So you need to convert to a Lasik or a femtoflap. So now what we're doing is doing a femtoflap. And just before the side cut, again, this patient moved and he had a suction loss again. So the Lasik flap was cut, but the side cut was not made. And so again, it was dogged. He was dogged again, and then the side cut was made. Now the question was, this was a patient who had opted for smile in both eyes, what to do with the left eye. But since he was so apprehensive, I didn't want to go in for a smile for the left eye. So what I did is straight away go went in for femtolastic for the left eye as well. So sometimes with some patients, you have to make up your mind. There's really not much point in going on trying again and again. If you've seen that the patient is not very cooperative, has a tendency for lots of movement, even despite all your reassurance, and in such cases, you might want to just convert to a femtolastic straight away. Now here's another case with both eye suction loss and a lot of bizarre events happening there. You can see that again, another uncooperative patient. So some of these cases, videos are from our trainee surgeons as well. So that eye, of course, was aborted, and we didn't go ahead with that eye immediately. So we went on to the next eye. So this is the first eye. I'm sorry, the video started playing all over again. That's the first eye. And now going on to the left eye, what's happening, as you see here, the lenticular cut starting and continuing, and then the lenticular side cut happening. And you can see there's a little bit of movement started by the patient already, and you can see that conjunctiva is actually getting pulled onto the interface, and that cap cut has actually gone partly into the conjunctiva. So that's an incomplete cap cut, obviously. Definitely nobody in the theater was smiling at that point of time. Everyone was frowning. Just to understand again what happened, the lenticular cut went fine. That's the diameter of the lenticular cut. That's the lenticular side cut, and there was patient movement happening already. You can see the lenticular side cut is not exactly aligned. The conjunctiva is starting to get pulled in. You can keep seeing the diameter of the lenticular cut there. The flap cut. So part of the lenticular, the flap is not, the cap is not dissected over the lenticule. So that's the part of the cap which is undissected. So you've got a complete dissection on both sides of the lenticule in this much area, but one part of the lenticule is not dissected, and the anterior surface. So that's basically the part that was not dissected when the patient seen upright. Again, in the lying down position, you have towards the right hand side the undissected part. So here we judged that the optic zone was fine enough to not cause severe visual symptoms, and dissection was continued. And basically, the lenticule was extracted, and we had about, on measuring, a 5.5 to 6 millimeter lenticule, a 5.5 millimeter lenticule, and the patient did reasonably well. For the other eye, the right eye, where we had aborted, we decided to do a micro keratome cut instead of a femtolastic at the same sitting. So we went ahead and did a micro keratome cut because I wanted a clean cut without any issues happening, and then that eye went smoothly. So this is a post-op first day appearance of the right eye, which was a micro keratome cut, and you'll soon see the left eye as well. That's the left eye, and you can see that area. That's the area where there was the intersection between the conjunctiva and the cap cut not having been cut. The patient ended up having a hypermetropic refractive error in both eyes, surprisingly, but he was a young patient, and he was able to see 6/6 with some amount of accommodation and was reasonably happy. So here's another case where there was a suction loss. And one thing that you really need to do is act fast before the bubbles disappear. In this case, the suction loss is at the incision, the smile incision stage. So you can see everything's going smoothly. And during that point of the smile incision, the patient moves. And most of this is generally because of an uncooperative patient, because you know that the vacuum that's created during smile is only about 35 millimeters mercury. So it's low vacuum, and any excess fluid or slight movement by the patient or attempts to kind of getting confused and attempting to fixate on the green light, especially when the first laser passes over and the green light starts to become less visible to the patient. Apprehension on the part of the patient can lead on to suction loss. So that entry cut is not there. So this case was by a trainee, and by the time they called me, I was trying to search for the incision, and we couldn't find any incision. There were no bubbles left to kind of guess where the cap cuts margins were. So this case was aborted, and femtolastic was later done. Here's an interesting case where they then learned the importance of asking for help immediately. So here's a similar case that's happening. You can see that many times this conjunctiva gets pulled in, and that's important, and especially can happen when you're doing repeated attempts at docking with a slight ballooning of the conjunctiva. So again, there's some area which is not clear. We've got a 6.5 millimeter, considering a 6.5 millimeter oocyte. What I did is I marked all around by taking about 3.25 and accounting for a 7.5 millimeter cap, which was what was calculated. I again marked all around. So basically what I've done is try to mark the borders of the lenticule as well as the borders of the cap as it would have been dissected. I made a freehand cut into the cap, and I'm trying to find that plane of dissection. So just enlarge that to a total of 2 millimeters because the initial cut was very small, and that's basically got you into that plane of dissection. And now if you look carefully, you can also see the posterior plane of dissection. So once we found that plane of both the anterior and the posterior plane, so that's that line there shows you both the planes of dissection, and that's the edge of the lenticule. And once you've done that, you go ahead and enlarge that incision to a total incision length of 2 millimeters. Go ahead and put your instrument wide enough. And the reason I'm doing it on the left-hand side, even though I'm a right-handed surgeon, is because this was the part where there was some conjunctival overlap and an incomplete cap cut. So I've gone till the edges of the completed cut, and then basically dissected under and above the lenticule and then extracted the lenticule. So we did have a slightly smaller lenticule, but you do get a larger final effective optic zone with SMILE than you do with Lasik. So this patient was happy post-operatively and did well. So another interest, so this is a post-op op scan for, pentacam for this patient, and basically she had a 6/6 right eye and 6/6 left eye, both eyes. Now, the case 2, suction loss incision with a freehand cut again. So here's again a suction loss that happened. What I did here is take the cone and just kind of applanate it over the cornea. It's obviously not attached to the Visumax machine. I just wanted to see where the edges of the cone would come, kind of create an impression. And then I did a freehand cut again. Here again, everything was over except the incisional cut. So this freehand dissection allows you to kind of see if you can enter that plane of dissection. It's a little superficial. The cut is not deep enough, so I'm going a little more deeper. Generally, we use 120 micron caps. And once that was done, we got into this plane of dissection. And then it becomes much simpler. So you can see the border of the lenticule. So the anterior and posterior planes are then cut, are identified, and you do you dissect both anteriorly and posteriorly, and finally extract that lenticule. And you can see the lenticules being extracted completely. That's a well dissected out lenticule. So in these ways, you can sometimes salvage the case. It's especially better if your fellow or whoever is doing the case marks the edges of the bubbles as soon as this happens, so that you know exactly where to put your manual cut and not have to guess. So that's the reason it's always important to know how the bubbles are. So this is a 10th post-op day of the same patient that we just saw. Manual cap cut, uncorrected visual acuity was 6/6, and the other eye which underwent an uneventful SMILE also got 6/6. So both the eyes did pretty well, as you can see here. Now, one sign that I'd like to introduce you to is the white ring sign. And I think I'll probably just stop with this one because I'm probably over time. So just the importance of this white ring sign, which I had described and was published in JCRS, is extremely crucial to know which plane of dissection you are doing. So the white ring above the instrument notes shows you that you're doing posterior dissection, and when the white ring is above, you know you're doing posterior dissection, and when the white ring is below, you know you're doing anterior dissection. So it's very, very important to know these, because you always want to finish your anterior dissection before your posterior dissection. And you can also get some other complications. One interesting complication that I'll show you is basically one with epithelial ingrowth, which can also happen post-SMILE. So you need to be careful not to get epithelial, especially defects near the incision. So here we did a circle cut. As you can see here, this is basically a circle cut which can be used to open a SMILE into a flap. So then you go ahead and treat the epithelial growth as you would do for a case of Lasik. And basically this is the patient post-operatively. The other little odd kind of appearance or presentation that you can get is an epithelial implantation instead of an ingrowth, which means that while you're dissecting, you're actually implanted some epithelial cells inside. So it's not from the incision, but it's deep within the pocket. And this is another strange complication that you can get after SMILE. With that, I'll come to the end of my presentation. Thank you so much, Ashraf, for having invited me here again. And I'll stop sharing.
Thank you, Susan, so much. It's a highly informative talk about the complication of SMILE, because everyone say that SMILE is without complication. It's very simple and very easy and just training. But I always say that SMILE it needs a very long training course, and you should know the complication before you start any SMILE case, because the complication is not easy to be handled like the Lasik or the femtolasic complications. So yeah.
Yeah, I think basically like every surgery, Ashraf, SMILE also does have its complications, but it is really not a difficult surgery as long as you have your concepts right. Many of these videos which I had showed were by training surgeons, and many of them you could see were also easily handled, and patients do well. the epithelial implantation may be a little more tough to handle. You would still want to do probably do a circle cut and then handle that, but first observe to see whether it's growing or whether it's static. If it's static and not growing, you could just leave it alone. The other thing is you need to know about the white ring sign, which is very, very important. And there's also another way of the way of dissection of the smile lenticule, which is also something that I published in JCRS, which I call a sequential segmental, lenticular side cut dissection. So that's again very, very important way, especially for thin lenticles, because thin lenticles are what can tear and possibly cause postoperative topographic abnormalities. So especially for thin lenticles, you need to be careful. And as long as you follow the techniques, anterior dissection first, followed by posterior dissection, keep anchoring points on both sides of the lenticule, so that the lenticule is not moving around freely, but rather it's anchored at both sides till you've almost finished all your dissection. These are important points which help you do a smile uneventfully.
Thank you, Susan, so much. We are honored to have you with us, really. And now we are going to move to Dr. Ahmed. Ahmed is my friend for more than 20 years now. He's an eminent retinal surgeon. He's an assistant professor of Cairo University, and he's also doing anterior segment surgery. But he's very famous in posterior segment surgery, and he's an eminent booming star now in posterior segment surgery. He's going to take us to if there is any challenging can happen during refractive surgery. He's going to talk about this. Ahmed, please talk.
Yes, thank you, Ashraf, for inviting me into this great webinar. I hope you can see my screen now.
Yes.
Yes. Okay. Actually, this topic is completely different from all the ones described in this webinar. I'm actually hitting the refractive surgery from a different aspect and from the opposite side of the eye. Probably this topic was not, it was not studied by many investigators, and there are not so many publications in this topic, probably because of the limited number of complications in this aspect, and because it's difficult to record these postoperative complications from the posterior segment part, from the posterior segment point of view. So actually, both corneal and lens-based refractive surgery have potential complications on the posterior segment. And we have to know that a myopic eye that undergoes a refractive surgery remains myopic in general in regards to the retinal pathology. So metropic eyes, compared to the metropic eyes, the myopic eyes have higher incidence of retinal complications. It is known that the incidence of rhegmatogenous retinal detachment in a myopic eye ranges from 0.7 to 3.2%, and possible retinal complications that could happen after refractive surgery include mainly retinal breaks, retinal detachment, macular hemorrhage, choroidal neovascular membrane, or macular holes. So looking at the corneal-based refractive surgery, actually, the increase in the intraocular pressure during the suction and flap creation results in various disturbances in the configuration of the globe. And as we can see here, there is an increase in the anteroposterior diameter of the eye, with a compensatory decrease in the horizontal axis of the eye, resulting in change in the vitreoretinal vector forces. This change in the vitreoretinal forces will result in vitreoretinal traction at different points, particularly at the vitreous base and at the posterior pole, which may predispose to early PVD. And this could be the pathophysiological event that may trigger post-operative complications. So retinal detachment is the most important possible complication after LASIK. Various reports and case studies have been reported from 1999 to 2012, reporting a variable incidence of post-LASIK retinal detachment ranging from 0.05% till 0.25%. Actually, these different studies had different inclusion criteria, different follow-up periods, and actually you can see this reflected in the different incidents that has been reported. All of these studies had a follow-up period from 2 to 10 years, and in all of the studies, the retinal detachment developed after LASIK, starting from 1 month up to 10 years. All patients had preoperative retinal examinations, and all patients had preoperative prophylactic treatment for the retinal pathology, while the patients with higher errors were more susceptible for retinal complications. So as we know that the incidence of retinal detachment in myopic eyes ranges from 0.7% to 3.2%, and as we study the results of the previous reports, we may conclude that LASIK patients actually had a lower rate of retinal detachment than the non-LASIK patients. LASIK did not increase the risk of retinal detachment. And the retinal detachment developing in myopic eyes that have performed LASIK surgery share the same characteristics to retinal detachment in myopic eyes that did not perform any kind of surgery. We also know that vitreoretinal complications after LASIK are extremely rare. However, this could be of great impact because of the large number of LASIK procedures performed nowadays worldwide. So a cause-effect relationship between LASIK and the reported posterior segment complication is still difficult to establish. Adding to this concept, one of the studies have given us some very interesting information, as we can see that patients who developed, 30% of the patients who developed retinal detachment after the LASIK procedure, they developed the detachment within the first 6 months after the procedure, while more than 60% of the patients who developed retinal detachment after LASIK developed after 12 months, suggesting that posterior vitreous detachment occurring at a later stage and not influenced by LASIK. Another study here has reported that LASIK did not induce or alter any peripheral retinal degenerations in highly myopic eyes in a follow-up period up to 6 months, and actually no retinal detachment developed in these eyes. Peripheral retinal degenerations that were discussed include the white without pressure, pigmentary changes, paving stone degenerations, and actually the lattice degeneration too. And patients did not develop retinal detachment within 6 months after surgery. On the other hand, it could be argued that retinal detachment may complicate LASIK in certain situations. One of the studies have reported that there's an increased incidence of post-LASIK retinal detachment in males older age and in higher refractive errors. Another study reported that there is a 9.5% incidence of new PVD after LASIK, which was confirmed by the B-scan. Another study have also reported that this rate of PVD could reach up to 24% in higher errors exceeding -6 diopters. High errors should be treated with caution according to these findings. We also have very few reports of early and or bilateral retinal detachment following LASIK. These very few reports have been published between the period from 2000 till 2018. But in all of these cases, retinal detachment could have developed either due to a missed preoperative retinal break or maybe due to an acute PVD in the early postoperative period. So what's the role of preoperative prophylactic laser for retinal lesions? This is still controversial. It's possible that the retinal complications may develop from the procedure itself, from the laser itself, or from the natural course of the pathology. We don't know. So actually, one of the studies published in 2003 have concluded that prophylactic laser for retinal breaks was effective in preventing postoperative retinal detachment. In this study, it was found that 2% of patients presenting for laser vision correction had pre-existing retinal breaks or holes, particularly in high errors. And it was also found that many of these tears or holes may be asymptomatic. So actually, these patients would not have any symptoms and have these tears or breaks accidentally discovered. In this study, they found that all patients that were treated with preoperative laser, a prophylactic laser for the retinal breaks, did not develop any retinal detachment during a follow-up period of 19 months. However, on the other hand, this was completely opposed by another study. It's another huge study published in 2005, which was analyzing and comparing preoperative retinal lesions, as in retinal breaks, tears, or lattice degeneration, and comparing them to postoperative retinal complications. In this study, they have found that all patients, 100% of patients with preoperative retinal lesions develop postoperative complications, either retinal detachment or retinal breaks. They also have shown even more that these patients who have received preoperative laser treatment actually did develop postoperative retinal complications as well. And the preoperative laser did not play any role in prevention of postoperative complications. And the prophylactic laser, they concluded that it doesn't guarantee the prevention of post-LASIK retinal complications. Now we move to the post-LASIK macular hemorrhage or choroidal neovascular membrane. Various reports of patients with macular hemorrhage or choroidal neovascular membrane have been reported, and this could be induced by the sudden, as in the microkeratoma assisted LASIK, or prolonged, as in the femtolaser assisted creation of the retinal flap, increase in the ocular pressure, which results in the distortion of the contour of the globe, increase in the anteroposterior diameter, and possible traction over the macula. The resultant breaks in the Brooks membrane should also give rise to choroidal neovascular membrane in these patients, and there was a reported incidence of 0.1% in high myopes. The risk factors for high myopia include the lacunar cracks and pre-existing choroidal neovascular membrane. and the treatment of the choroidal endovascular membrane with anti-VEGF therapy provides promising results. Post-LASIK macular error is another complication that was reported in very few cases, and there was an incidence of 0.2% in a great series of 55,000 patients, and all of these patients had have shown that they developed post-operative percent. IOLs or the general the refractive extensions. And for every 1 millimeter increase in the event, we have a 1.5 times factor increase in the incidence of retinal detachment. We have to bring refractive view and using the square edge type range from 0.32 and conclude that comparative prediction, the lens not increase the risk of retinal detachment. However, macular hemorrhage was reported in the Icl group and choroidal vascular membrane in the artisan group. Macular holes, again, we have a very few case reports of macular holes which develop phakic IOL vitrectomy. This is a vitrectomy for a patient who implanted the anterior chamber cachet lens, which is obsolete now, and developed retinal detachment 8 months after the surgery. We have some surgical considerations here. If we are planning to remove the lens or they perform the phakic emulsification, and if the clear lens, if the crystalline lens is clear, I think we have to postpone this procedure for the second procedure with silicone oil removal in order to increase the chances of accurate biometry in a flat retina. Cases planned for gas tamponade, actually we have to perform the phakic emulsification, removal of the lens with the vitrectomy because the gas is highly cataractogenic. While if we plan to keep the patients on air, we can leave the phakic IOL and the crystalline lens in place. In case of air or gas tamponade, we have to take care that post-operative intraocular pressure has to be monitored because of the forward displacement of the iris lens diaphragm, narrowing the angle and increasing the intraocular pressure. And again, biometry considerations are the same as in the post-Lasik case. So in conclusion, the role of prophylactic laser treatment in preventing retinal complication is still controversial. Out of different reports, we may conclude that retinal breaks, holes, may be treated before performing refractive surgery. Peripheral retinal degenerations without breaks or holes, like the lattice degeneration, white without pressure, caving stone, pigmentary or cystic degenerations should be followed up after surgery. Careful and meticulous preoperative examination with scleral depression is important for localizing and treating retinal lesions. Highly myopic eyes are specifically at increased risk for vitreoretinal complications, irrespective of the refractive procedure compared to low myopic eyes. And finally, careful postoperative monitoring of the highly myopic eyes is important to detect occurrence of the postoperative lesions that may occur in the natural course of the myopia. And since we have no cause-effect relationship between refractive surgery and retinal complications, patients should be informed that refractive surgery only corrects the refractive state of myopia, and that myopic eyes may still have the potential for serious complications. And thank you for your attention.
Thank you, Ahmed, so much. It's an excellent presentation, as I expected. You cover it from A to Z. And thank you for your last statement that refractive surgery is going to correct the refractive problem of the patient and does not, but myopia has its complication, does not relate it to the refractive surgery. This is very important. This is, as Eric mentioned in the early of this webinar, that we are not talking about complication of refractive surgery, but we are talking about what happened in an eye susceptible to complication, not the refractive surgery procedure by itself. You have a question from the audience, Ahmed. What is the time between laser before laser for the retina, if there is a macular hole or a susceptible problem, and the time of refractive surgery?
Yes, I would perform the laser, the prophylactic laser for retinal breaks or holes, and I will perform the second the surgery for the phakic IOL, for example, at least 1 month after the laser. At least. Some authors may say 2 months, but 2 weeks, but I will go for 1 month after the surgery to ensure the complete stabilization of the scar and complete closure of the retinal break or hole.
When you have a patient for refractive surgery and you examine the fundus, when you tell the patient you are not a patient candidate for refractive surgery, either corneal or an ICL?
Actually, yes, this is debatable. As I've said, this is a subject of debate whether prophylactic laser plays a role or not. But as for myself, I go for prophylactic laser for any preoperative retinal lesions, but not all for not for all lesions. Of course, retinal breaks, retinal holes with an operculum or not, I would go to treat all the retinal holes that are available. Lattice degeneration, I would go and treat the lattice degeneration, but I would make sure that the laser spots or the laser burns at least 1 spot size away from the margin of the lattice in order to not to exert more traction on the lattice or the area of the thinning, and it could be a source of more traction and giving rise to more holes. And I have to wait for a considerable period of time, at least 1 month before performing the surgery. I would treat all retinal breaks, I would treat retinal holes, and if I have retinal pathology in more than 1 quadrant, I would go for 360 laser all around the retina.
If there is any relationship between the state of the vitreous and the retina and the incidence of complication in myopic eyes?
Yes, actually, if you don't have a posterior vitreous detachment, if you have a posterior vitreous detachment, you have no problem. But the problem comes when you have incomplete vitreous detachment, because when you go for a YAG, for example, after a refractive lens exchange, and you go for a YAG capsulotomy, and you go and make opening of the posterior capsule, and inadvertently you can open the anterior hyaloid, and this opening in the anterior hyaloid would cause the liquefied vitreous in these very high myopes to escape in the potential space between the vitreous and the retina, predisposing to premature vitreous separation. This premature vitreous separation in the young patients who have very strong attachments with the vitreous is very dangerous, because it induces very early premature vitreous separation due to the premature vitreous liquefaction, and here comes the danger of retinal tears.
Thank you, Ahmed, so much.
Thank you. I have a last question for you. Do you advise that old PRK or trans PRK could be advised in a patient without posterior vitreal detachment?
Trans PRK, you mean?
Yes, trans PRK or normal PRK.
Actually, there was not a single study involving the PRK. I mean,
in your practical life.
In my practice, I wouldn't consider trans PRK as a potential risk for the retina. Actually, it's an untouched technique, so I wouldn't consider it as a potential risk for laser. But in general, you have to examine the periphery of the fundus of all these patients because they are liable for complications even after you complete the procedure later in life, because as a part of the natural course of the disease, they may develop later on complications. So you have to inform the patients anyway.
I have a comment on this because we used to know that a retina patient with previous vitrectomy or previous retina detachment surgery is contraindication of refractive surgery. But sometimes you can do PRK on this patient because you don't have the suction, so you're not putting the patient on the risk of retina detachment again. So if you can do PRK in cases of buccal, after buccal, or after previous vitrectomy or stuff like this, you avoid doing suction Lasik, whether in the form of microkeratoma or filtration.
Yes, I would believe that the laser, that the scar from the retinal cryopexy or the laser retinopexy is very strong. You can go for a suction ring, but I would recommend the femto laser in this case because of the intraocular pressure doesn't rise that much in the femto laser femtolasic treatment. It should, although it rises for a longer period of time, about 40 to 50 or 60 seconds sometimes, but the rise actually is not that increase or sudden decrease and increase in pressure as in the microkeratoma assisted Lasik.
Yes, of course, but you know it's a classic contraindication of doing Lasik or that he has a previous retinal surgery. But now I think you can do PRK safely without putting any kind of suction, at least for medical rigor purposes. Yeah.
What will you do if the patient is not fit for PRK? If he has high errors, if he's a hyperope?
There's another issue, of course. I would go for lens-based or let the patient use his glasses.
We will do another webinar on hyperopic trans PRK. That is really.
But I can definitely assure you that we do cataract surgery. Actually, we do cataract surgery for patients who had previous retinal detachment surgery. So we look at their fundus and we find that the retinal tears are completely sealed and scarred. If they have performed cryotherapy or have performed laser, the retinal scar is very strong. And I'm not afraid of this particular scar. I may be afraid of another.
You are a veteran retinal surgeon. You are a veteran retinal surgeon. After your presentation, we'll stop doing refractive surgery. Actually.
No, go ahead, don't mind. Go ahead when we're out. We are behind you.
More than this, we have to prevent the common worst complication that is medical claim.
Yes, that's another issue. That's another issue. Yeah.
I think the message to take home for our in this webinar is that you have always to do the safest things for the patient.
Of course.
And what I personally learned from you is they have to do a ecography before operating each patient, because information about posterior vitreal detachment sometimes could really change your technique.
Yes, definitely. Yes.
Okay, we come to our final. I'm just going to say again that the aim of this webinar, it was not the complication of a refractive surgery, but it was how to manage the challenging situation that can happen to any surgeon during any part of the refractive surgery, whatever it is. Cross-linking, surface ablation, cross-linking, ICL, or even a smile, and for sure, posterior segment problems in an eye susceptible to a complication before the refractive surgery. I would thank everyone, Renato Ambrosi from Brazil, Cosimo from Italy, Miguel from Italy, Tariq Nagar from Egypt, Ahmed Sawi from Egypt, for sure Susan Jacob from India, and Eric Martins from Belgium to have this highly informative webinar. Thank you, Renato, so much. I know you are busy in your clinic, I am sure. So thank you so much for being with us. I am really appreciated this. Thank you so much. Thanks for everyone.
Thank you, Tara. Thank you, Miguel, and thank you for all the participants. And see you again in another webinar soon.
And thanks to Eva for all this support. Thank you so much. Thank you, Susan, so much. Thank you so much.
Thank you.
Thank you. Bye bye.